Hello again. Everyone who works in acute care is afraid of missing a serious infection, one that could cause major harm or even kill your patient if you don't recognize it and treat it in time. And it's often difficult to make the right diagnosis early when the patient may not look all that sick. This ever-present uncertainty is a big reason why we tend to overprescribe antibiotics. And we've all heard of or even witnessed horror stories where a clinician really did fail to recognize a serious condition, then the patient deteriorated, ended up in the ICU or worse, and everything turned into a nightmare, right? So, in order to make our lives easier, experts and expert societies have been trying for decades to come up with a set of simple, clear criteria for the diagnosis of sepsis, which emerges as a result of uncontrolled infection. So, let's see what they came up with. When I started out, the definition of sepsis required two things: the presence of infection and SIRS, or systemic inflammatory response syndrome. So if your patient has some kind of infection and SIRS, this was sepsis. What kind of infection, you might ask? Well, the guidelines never specified how exactly you were supposed to diagnose an infection. It was assumed that you would somehow get this part right on your own. I mean, how hard can it be, right? There are only hundreds of different infections with different overlapping symptoms. There are hundreds of non-infectious conditions that can mimic infections like autoimmune diseases or cancer, right? But okay, for the sake of simplicity, let's assume that you really did correctly suspect that your patient does have an infection. In order to diagnose sepsis, you needed at least 2 out of the following 4 criteria for SIRS, for systemic inflammatory response syndrome. Temperature above 38 degrees Celsius or below 36, heart rate above 90, respiratory rate above 20, and leukocyte count above 12 or below 4. So, if your patient with a suspected infection had at least 2 out of these 4 criteria, this was sepsis. Simple, right? Well, the thing is, if you have any experience as a medical professional, you will notice a glaring problem, as I did when I first set my eyes on these criteria. Many people with very mild, even self-limited infections will fulfill criteria for SIRS. They will have fever. Most of them will have fever about 38 at some point, right? Many will have a heart rate above 90, especially if they're afraid of you as a doctor, right? Many will have a leukocyte count above 12. Strep throat has no problem raising leukocytes above 12, so does mild pneumonia. And respiratory rate, well, let's be honest, most doctors don't really measure respiratory rate. Not to mention that there are many non-infectious conditions that can cause SIRS. So how can you know that this is an infection rather than a non-infectious process? So this goes back to the first problem, right? All in all, as you can see, these criteria were rather unspecific. It was clear that the new improved definition was needed. And sure enough, in 2016, a new definition of sepsis did come out, and this time sepsis was defined, pay attention to this, please, this is important. Sepsis was defined as a life-threatening organ dysfunction caused by a dysregulated host response to infection. And as I always say in all of my lectures, I think that this definition is absolutely perfect. This is exactly what sepsis is. It's life-threatening, and it's a result of a dysregulated inflammatory response to infection, which leads to organ dysfunction. Okay, so now we know what it is, but still, how do you diagnose it in a clinical setting? Which criteria do you use to actually diagnose sepsis? Well, here is where we come to the major problem. First of all, in 2016, we still didn't get clear instructions on how to actually diagnose or even suspect an infection. So, no progress in that department, but what about the second half of this definition? What about organ dysfunction? We can diagnose that, right? Right? Well, see, in 2016, we didn't exactly get a diagnostic tool for sepsis. We got a risk assessment tool instead. What is that, you might ask? Basically, you get a set of criteria, and if your patient fulfills these criteria, they are more likely to die from their infection than a person who doesn't fulfill these criteria. But we won't call that sepsis, no, because that would be a diagnosis. And remember, this is not a diagnostic tool, this is a risk assessment tool. The guidelines emphasize this very clearly several times. So let's take a look at this groundbreaking risk assessment tool, shall we? If at least 2 out of the following 3 signs are present, your patient is much more likely to die. The 3 signs you should always look for are altered level of consciousness, hypotension, and rapid breathing. So basically what this scoring system is telling us is that a hypotensive person who is breathing rapidly is very seriously ill. A hypotensive person who is also disoriented is very seriously ill. A disoriented person who is breathing rapidly is very, very seriously ill. Wow, what a revelation. No shit, Sherlock. This is what hundreds of world-class experts came up with. This. And by the way, this scoring system is called qSOFA, or Quick Sequential Organ Failure Assessment. Now, in all of my lectures on this topic, I always ask, who the hell needs this scoring system to tell them that a hypotensive, disoriented person is seriously ill? By the time your patient scores 2 on qSOFA, they will be so sick that a chicken will be able to realize that they are sick. Moral of the story, please, for the sake of your patients and your career, do not use qSOFA as a diagnostic, risk assessment, or any kind of tool in the diagnosis of sepsis. Do not use it as a screening tool for sepsis. Don't use it for anything for that matter. If you are compelled to enter your patient's qSOFA score on a piece of paper because a bureaucrat is making you do this, okay, so be it. But in terms of clinical decision making, do not use qSOFA for anything. It's absolutely useless. I don't know how it even exists. It's one of the worst things in modern medicine. And this is not just my opinion. Many experts, many institutions still refuse to use qSOFA. They stick to the old criteria for sepsis, right? Infection plus SIRS. They are fully aware that these criteria are not perfect, but they are definitely better than qSOFA. There are also other scoring systems, but the truth is, no scoring system in the world will ever replace solid clinical thinking. There is no magical formula, especially not one as stupid as qSOFA. Having seen thousands of patients with all sorts of infections, ranging from simple cold to fungal meningitis, I do agree that the clinical approach to a patient with a suspected infection should be simple, but not that simple. Not as simple as qSOFA. And that is why I do this. Not just this video. I created a series of lectures where I describe how a thinking clinician should approach a patient with a suspected infection. In these videos, you will learn what I wish someone had taught me before I even started out. Something that everyone who works in acute care just has to know. The link to the videos is in the description. They are free, of course, because I want everyone to learn this. You can skip lessons, you can go right to the topics you are interested in, but I would strongly recommend that you watch the whole thing from the beginning. You will get the most value out of it. And if you like it, which I guarantee you will, please share this course with your coworkers, with your students. It will transform the way they think about serious infections and sepsis, and it will help them a great deal in practice. Thank you for watching, good luck and take care.